Despite spending much more on healthcare than any other country in the world, the health of the people in the United States is far from the best in the industrialized world. In fact, we are steadily falling farther behind in such categories as life expectancy, infant mortality, and overall well-being. In addition, we have some of the greatest health disparities in the world. The question is, why do we have such poor outcomes and such great disparities? Is it because of poor quality and too costly medical care? Poor lifestyle choices by Americans? Unhealthy public policies? Poverty and income inequality? Lack of investment in social services and basic needs like housing and food? High rates of incarceration, discrimination, our societal structure? Or is it all of the above or something else? These questions may be difficult to answer, but it's important that we address them. So on today's episode of A Public Health Journal, we're going to look at the issue of poor population health, health disparities, and health inequity. We'll also be looking at causes and possible ways to address the problems. It promises to be an interesting conversation. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to have a conversation about health disparities and health equity. These are issues that have gained national attention and certainly here in Minnesota. They are certainly health issues, but they are also moral and ethical issues. Because of that, I've invited Dr. Steve Miles to join me today. Dr. Miles is a physician and professor of medicine and bioethics at the University of Minnesota. He's been engaged in addressing numerous difficult ethical issues like physician involvement in torture, pharmaceutical pricing and marketing, healthcare insurance, end-of-life care, and the use of restraints in nursing homes, among many other things. He is well qualified to talk about the bioethics of health equity. Steve, welcome to our program.
Nice to see you again, Ed.
Yes, it's always fun to have you on here because I never know quite where the conversation is going to go, particularly in a topic like health equity, which is a huge conversation and has many variables and many components to it. But let's start out by how do you characterize the health of the United States, particularly compared to other places in the world? As I mentioned earlier, we're falling behind other countries in terms of the statistics. How do you characterize that?
Roughly, we're at the level of Costa Rica. That is, we are far, far behind our other industrialized peers. And not only are our outcomes poor, but our costs are high. We're spending roughly twice what other European, Japanese, and Australian healthcare systems are for these poor outcomes.
Mm-hmm. Now, Minnesota, we always pride ourselves as being one of the healthiest states in the country. Are our issues different than the rest of the United States?
The major advantage we have is that we are less diverse. And the second advantage is that our entitlement programs for healthcare are better. But ultimately, it's not the delivery system, the clinics and hospitals that provide public health. Rather, it is issues like income disparities, stability in schools, and so forth.
Mm-hmm. All right, I have a slide here. You talked about health care, and I think most people believe that health is about good medical care.
Correct.
If they just had insurance and good medical care, and they'd made proper choices about cigarettes and alcohol, they'd be healthy. But tell me what you're seeing in this slide.
Well, what this slide shows is that clinical care is a small part of it. And it is true that cigarettes and alcohol are a big part of the problem, but it's interesting that the United States is actually at the low end of cigarettes and alcohol compared to other industrial countries, and we still have bad outcomes because we've got these other issues in our society. When you take a disease like tuberculosis, which was the #1 killer in the year 2000, we basically
about year 1900.
1900. We got 90% drop in tuberculosis before the first antibiotic came out for it. It was public health.
Mm-hmm. Now, in this slide, which shows 40%, and I think actually more, are socioeconomic circumstances. Tell me that kind of influence that socioeconomic conditions have on health.
Sure. Why don't you throw up your second slide?
All right, so we do have another slide here that shows in the Twin Cities area along the I-94 corridor that life expectancy varies by about 13 years within a 3-mile radius. And when we get that up, we'll be able to see that graphically. But really does point out the fact that there are some other factors other than healthcare that make a difference. And so here's the slide.
Exactly. You can drive, for example, say from roughly Frogtown out to Minnetonka or Hopkins. And what you see is a 13-year increase in life expectancy. Now, you can look at what do you see as you go along there. First off, the families are a third as likely to have homes. And not coincidentally, the students are 3 times as likely to switch schools in the middle of their schooling. What does that mean? That means that learning disabilities are less likely to be picked up by their teachers. It means that the relationships between the teachers to pick up abuse in the homes are less common. It means that more effort is spent screening kids than treating kids with various health-related disabilities that are affecting learning. And all of these issues affect healthcare outcomes.
So why does that occur? Why do we have these clumping of different kinds of conditions?
Well, one of the fascinating things was that when we were aggressively practicing racial segregation, we prevented the formation of capital inside of particularly minority groups so that they became less likely to buy homes and then less likely to pass that wealth down to their kids. And this resulted in both a concentration of poverty, but also resulted in a lack of home ownership, which then translates into shifting school patterns, which then translates into one aspect of poor health outcomes.
Mm-hmm. So you're saying that, and it's what I've been talking about, is that personal choice, as important as it is, really is dictated by a lot of other public policies and social policies, so that people didn't choose necessarily to live in bad neighborhoods. They were sort of forced to do it by some of the public policies.
That's exactly right. And that's why we have to be very careful, for example, about using race as a measure of health disparity and focus instead on what the health department does, which is on health equity. Mm-hmm. If you take, for example, stroke, everybody says, well, the rates of stroke are 35% higher in African Americans than in the white population. But the fact is, if you correct for socioeconomic status at birth, socioeconomic status at middle age, obesity as a kid, 85% of the difference between blacks and whites goes away simply by doing those corrections, which are never done in most public health papers on the subject.
Mm-hmm. But we do know, I mean, that African American women, college-educated African American women with a middle-class income have poorer birth outcomes than white women with less than a high school education and poverty.
Well, yeah, but we also know, first off, that the total genetic difference between African Americans and the white population is about 1/50th of 1%. This is not a major determinant of health. A little extra sickle disease here, a little extra multiple sclerosis there, a little extra Tay-Sachs there, but this is not a big outcome. If you take, for example, African Americans over 65, they actually have a longer life expectancy than whites. And if you take African Americans who are or African descended persons, say in Europe, they do not have the types of bad outcomes that we see in the United States, because they're in a different social context.
All right. This is a really important concept for us to talk about, and so I'm going to come back right after this break, because I think we need to have a lot more conversation, because this is a hard conversation for people to have, a difficult conversation, and it needs to happen. But I'm going to be back right after this message.
Every day across America, excess food is gathered by a network of good people at local food banks, giving hope to millions of children who struggle with hunger. They've earned their wings, and you can too. Together, we can solve child hunger. Support Feeding America and your local food bank at feedingamerica.org.
Welcome back. We're talking about health equity in Minnesota with Steve Miles from the University of Minnesota. Steve, we started talking about race, which I agree that there's genetically race, there's really no differences between the races genetically. It's about skin color, it's about social construct, it's about how people get treated in our society. And you pointed out some of the things. We've noted that African-born black women, infant mortality rates are similar to whites. U.S.-born African-American women, their birth infant mortality rates are double that of whites. And the longer people stay here in the United States, if they're black, their infant mortality rates start to increase. So there must be something toxic in our society.
Well, it's very interesting. For example, if you look at levels of high blood pressure in Africans who live in Africa, and then as they come to the immigrant to the United States, what you see is a progressive increase in the blood pressure in those very same people. And that the U.S. environment is toxic. It's not just salt in the diet, but rather it is the chronic stress of the U.S. environment as it applies to people with dark skin that creates what appears to be a genetic difference, but which is really a social or medical manifestation of structural racism.
This is one of the things that we've been learning from the adverse childhood experiences data, that shows that the stress that infants and young children have, be it incarceration of their parents and marital discord and violence and sexual abuse and drug use, that stress actually becomes toxic and changes how their brain is and impacts their health long term. So we also have toxic stress from historical trauma with American Indians and African Americans in particular. So you're saying that it's that toxic stress that actually impacts their health long term.
Now, for example, just the phenomenon of moving a kid from one school district to another, which is 3 times as likely to occur in minority populations than in white populations. That itself is a stressor that has a health outcome effect. And when you have a health outcome effect in school, you're a less effective learner, and so it has long-term vocational effects, and also decreased literacy by itself disenfranchises a person from picking up health information that is spread in the popular culture. For example, anti-smoking or STD pamphlets. So this has a broad ramification for what happens to people's health.
Mm-hmm. So in this, so we're all talking about sort of the determinants of health, and we have 10% of health is determined by clinical care. And being a physician, I want to have good clinical care, and we want high quality care, but we don't want as many people to have to use it. But and we spend 95% or more of our total health dollars on medical care, and other countries do it a little differently than that. Are we investing in the wrong things?
I think that we are investing in the wrong things, because one of the things that's very interesting is you can plot the healthcare outcomes according to the spread of income in a society. There's a statistical technique for doing that. And the United States is actually a society that goes like this, but other countries in Europe have much more larger middle class distribution of wealth and income. And one of the things is that the healthcare outcomes is basically associated with how little disparities there are. And we are a society with unique economic disparities. Now, it's fascinating. We are spending in Minnesota an extra $1 trillion simply because of our failure to address health equity. And this is not a problem for minority populations. This is a problem for our total economic development. And if we don't address this issue, we basically put an enormous extra tax over and above healthcare expenditures on our state economy.
This gets at the point, why should people at the top care about health equity? Why should they care about disparities?
Well, $1 trillion is nothing to sneeze at, no matter how many yachts you have.
So there's an economic argument, and certainly as we become a state increasingly diverse. When I moved to Minnesota in 1980, we had 2% people of color and American Indians. It's up to about 20%, and about 35% of second graders are kids of color and American Indians. We're diversifying, so economically we need a workforce and an educated population to really be a good economic engine.
Well, for example, you take, for example, kidney disease. In the United States, kidney disease is especially much more likely to progress early. The early signs of kidney disease are much more likely to progress to dialysis. Dialysis is very expensive. Treating early kidney disease is cheap. But when you look at the progression to kidney failure in blacks, it's 6-7 times higher because of the disparities issue. Similarly, you look at your own data, and what you see is that whites actually have more breast cancer than African Americans, but they have a much lower death rate from breast cancer, which is basically wasted resources and also wasted human capital in terms of the people who we are losing who could otherwise be productive members of society.
I'm struck also by the fact that U.S. whites, the U.S. white population, doesn't live as long as the white population in other industrialized countries.
No, actually we are the shortest.
So that means that even the people at the top here aren't as healthy as people in other countries. And so I'm seeing some evolving research that says actually the lower the disparities, actually everybody benefits, even the people at the top. And it's sort of what Paul Wellstone said, when everybody does better, everybody does better. Are you seeing that? Is that an issue?
Yeah, it's, one could call it trickle up. I mean, the healthier a society is, the healthier all of the people are on average. And we have an interest in the health of other people. It's not just infectious disease, but it has to do with the general health of society. Untreated mental illness hurts all of us, whether it's a person who shoots somebody, whether it's a suicide that takes out a key employee in a Minnesota firm. And suicides, by the way, are, I don't know, about 5 times as common as homicides in Minnesota, and we don't know it's the homicides that are the front page of the paper. So it's a big deal.
All right, I want to talk sort of where we go from here, but we need to take another break.
Okay.
We'll be back right after this message.
So they say it's a man's world? I don't see anybody's name on it.
While they were doing their thing, we slowly changed all that.
Today, women can do anything men can do. And there's one thing we're even better at.
Welcome back. We're having a conversation about health equity with Dr. Steve Miles from the Center for Bioethics at the University of Minnesota. Steve, I want to make sure we talk about one thing because it's used a lot. It's the term social determinants of health. The World Health Organization has a whole framework of how to address social determinants of health because they see those as the biggest determinants of health. So when we talk about social determinants of health, what are we talking about?
We're talking about, first off, income for housing. We're talking about transportation. You've got the very nice green line going down past Lake Nokomis. Why didn't we build that spur up through Broadway? We should have built that spur up through Broadway through our impoverished neighborhoods, and it's still on the drawing table. You can't have good jobs unless you can get around, and we built that train to not serve poor neighborhoods. It's a question of schools. It's a question of schools' ability to have relationships with kids that last, that are long enough for them to effectively teach them. And that requires stable housing, which we also lack. It requires a non-toxic food supply. And one of the things that's so interesting when you look at the contents of grocery stores across the city, I saw a great study on this recently, is that in the suburban and wealthier neighborhoods, the content of the food that's available is more fresh vegetables, lower carbs, less toxic food products. Whereas if you go to the inner city markets, it's not only higher priced, but it's lower quality foods. It's much more fat and much more carb. And it relates to the presence of pollutants. We have, for example, you can map the presence of lead in soil, pretty much across the poor neighborhoods of the city. And lead is a well-known brain toxin. So the social determinants of health extend way outside of the doctor's office, which is why we have to deal with them.
Oh, and the social determinants are actually predicated or created by policies and systems that we put in place. That they didn't happen by accident.
No.
They were there because of the policy decisions.
Our history created them.
Yeah. So one of the things that in our country in the last 8 years, we've put together something called the triple aim of health care, where it says improve the patient experience, lower per capita costs because we spend so much on health care, and improve population health. I argue that that takes an individual focus, and actually by doing that actually may be detrimental to health, because individuals don't live outside of communities, they live in communities, and communities, as you pointed out in that second slide, actually impacts their health. What do you think of that triple aim of health care?
You know, it's very tempting to focus on things like, technology and data collection and all that fancy stuff. And, you know, healthcare is lived basically inside the house and inside the neighborhood. And so that if we're going to improve health in Minnesota, we don't solve that from inside the IT departments of hospitals. We solve it in the neighborhoods. Now, you take the Frogtown neighborhood, which was, run over by the 94 freeway. A group of citizens groups got together and just opened the Frogtown Farm and Park. A magnificent thing. Part of an overall goal to make every kid in the Twin Cities area within 10-minute walk of a park. That's public health.
All right, so that gets to the point. What do we need to do if we're going to really be a healthy state? If we're going to eliminate the disparities, which we've talked about are affecting everybody, how do we start?
Well, we need to continue with the issue of expanding insurance. We need to go back to the issue of statewide funding of schools to eliminate the fact that the rich districts are able to concentrate more resources on their kids, whereas the poorer districts with lower property taxes have fewer funds to spend for their schools. We need to eliminate job discrimination and mortgage redlining practices, and we need to hold banks accountable to issuing mortgages equitably, and we need to find better ways to allow people who have less wealth to accumulate wealth so that they can stabilize their home situations, because it is stable homes that actually are the foundation of public health.
So what you're suggesting is a little different than what springs from sort of the worldview that we have, the narrative that we have in our society, that it's rugged individualism. People put themselves up by their bootstraps, and that's the free market economy that actually is there, and that technology is going to solve it. It sounds like we need to change the narrative about what creates health.
Well, even Ayn Rand, who was the leader of the libertarian movement, wrote a poignant essay saying I was wrong as she signed up for Social Security and Medicare. So yeah, I think we need to change that narrative, because ultimately we're all swimming in the same pond, and when the water's dirty, it's dirty for all of us.
Yeah. And so how can we change that narrative? Who needs to get involved?
You know, to some extent, the kids are past it. The kids are less likely to see race as a central experience and more likely to see character, and I think that's good. They're more likely to engage in collaborative projects across income levels. And so as a university professor, I guess I see a lot of hope in that direction. And I think that it's up to the adults then to realize that ultimately sharing creates a better world for all of us.
And as I'm seeing in the news and seeing what's going on in the Twin Cities, we're really getting a lot of gentrification of the inner cities, and actually the poverty is moving out. How do we prevent from becoming like what some of the European cities are, where poverty is on the suburbs and all of the wealth is in the inner city?
Well, Minneapolis at the end of World War II actually did not annex its suburbs and wound up with the issue of concentrating poverty and ethnic groups on the inside of the city boundaries. So I don't view the movement of diversity out into the burbs as necessarily a bad thing. I think that the shift to from city government to county government is actually a good thing for public health. And the issue will be to develop a more inclusive state governance that actually embraces more of our people within larger governance units, rather than continuing these small little governance units of highly homogeneous populations which think they're defending their own interests when they're really not.
Yeah, good. Well, it's a good way to end. We've got a lot more to talk about. This has been a fascinating conversation. Thanks for being with us.
Thank you.
And I'll be back with a closing comment right after this message.
This is the story of a boy who is very sensitive to lights and sounds. So he built secret hiding places where nothing could get in. The boy didn't like looking people in the eye. It made him feel uncomfortable. One day, he found out he had something called autism. His family got him help, and slowly, he learned how to live with it better.
Early intervention can make a lifetime of difference. Learn the signs at autismspeaks.org.
Advancing health equity is the central challenge facing Minnesota today. With our rapidly diversifying population, if we don't reduce our health disparities, we will not be able to maintain our status as a healthy state. With that in mind, we proposed a triple aim of health equity. The first aim is to expand the understanding of what creates health. This means that we must recognize that health is created by much more than just medical care and personal choices. It's created by healthy and thriving communities, where the social, economic, environmental, and educational circumstances provide everyone with what they need to be healthy. Second, we need to adopt a health in all policies approach to health. That means that the policies and programs in areas like housing, transportation, economic development, education, and public safety should include a health lens as part of their implementation. And third, we need to strengthen the capacity of communities to create their own healthy future. Communities know best what they need to be healthy. And if they work collectively, they are most effective in addressing those needs. Health is best created in a vibrant democracy where citizens are actively engaged in creating and implementing the policies that affect their lives. Embracing the triple aim of health equity will change how the fields of public health and healthcare actually do their work. It'll also change how communities function. But this is a change that is absolutely necessary if we are to be a healthy and equitable state. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.